Knock, knock, knock.
Hello.
Hello, Mr. Brown. I am your nurse, Joe.
Hey, Joe.
This is Nurse Jessica.
Hi, Jessica.
Hi.
And this is Mary Kay, our student nurse.
Hi, Mary Kay.
We'll be looking after you today. How are you feeling today?
Just having difficulty breathing the past week or so. Just answering those no questions is not a problem, but, you know, when it comes to turn the TV off, no problem. Turn the TV on, I want to watch something. Yes, dear. It just takes it out of me. It's hard.
So you have a shortness of breath?
Yes.
Okay. Well,
Do you have I see that you have a history of hypertension and pneumonia.
A couple bouts with that in the past, yes.
Okay.
No fun.
Well, we're going to get some vitals going. How about you lay down, get a little comfortable. We'll raise the head of the bed so it's not so hard to breathe. Mary Kay, do you think you can start those vitals for us?
Sure.
Are you experiencing any pain right now?
No pain.
No pain? Okay.
about any weight changes lately?
I don't think so. Not that I'm aware of.
Okay.
Any swelling or edema?
It doesn't feel tight or anything. I don't know.
I'm going to go ahead and check your feet and your ankles.
Okay. This is kind of dizzy there for a second.
His O2 sats are only 91%.
Okay. You know what? I'm going to get you some oxygen. We want those O2 sats to go up a little bit higher.
Okay.
A little bit more normal range. I'm going to put you on 2 liters right now and see how that works out for you.
Okay.
Alright.
Mr. Brown's vital signs are blood pressure 132/80, heart rate 90, respirations 18, O2 saturation at 91%, and weight 195.
There's no edema.
Okay. You know what? I'm going to listen to your lungs.
Oh yeah. Cool.
Take a deep breath. And can you sit up for a second? All right. Well, your lungs are clear.
Oh, I'm glad.
I'm going to go ahead and get a blood draw. We're going to take some labs for you.
And then we're going to set up an EKG. We would like to see how your heart's doing. So I think our student nurse will do that right now for us.
Okay.
So do you look at that for us, Mary Kay? Sure.
Set this here.
Thank you.
So Mary Kay, just let me know if you need any help with the EKG placement, okay?
Okay, thank you. Mr. Brown's lab values show elevated neutrophils at 73%, normal range is between 50 and 70%, and this slight elevation could indicate an acute infection. He also has a decreased level of lymphocytes at 14%, normal range is between 20 and 40%, and this can indicate a viral infection and or immune deficiency. Mr. Brown has an elevated BNP level of 258. Normal range is less than 100. BNP is a hormone produced by the ventricles and is secreted in response to increased stress on the heart. BNP dilates the arteries and blocks the release of adrenaline so that sodium and water is excreted in the urine. This is the body's natural protective response to reduce the blood pressure. As the disease progresses, the BNP level rises, and with treatment of heart failure, the BNP decreases. The EKG shows ST and T wave abnormalities consistent with anterolateral ischemia and or infarct.
This is Dr. Kildare.
Hi, Dr. Kildare. It's Jessica from ED. I have a patient, Michael Brown, 71 years old, and he has come in here experiencing shortness of breath on exertion, but has been denying any pain. He is a non-smoker and a non-drinker, and he is physically active. He does have a history of prostate cancer, does have hypertension, he does have hyperlipidemia, and has had 2 episodes of pneumonia over the past 10 years. Current vitals are 132/80, heart rate 90, respirations 18, and his O2 sat was 91, but we just put him on 2 liters of O2, and now he is up to 95. Currently, his meds are clonidine and Coreg. His lungs are clear. In his heart, we heard a soft ejection murmur at the aortic listening point. S1 is normal. He does have an accentuated S2, S3 gallop. He does not have edema, so he is not experiencing any weight gain. His pulses are full and equal. We did do some lab work, and we did put a 12 lead on him. His lab shows an elevated BNP, which is 258, and his EKG showed ST segment and T weight abnormalities. Just trying to figure out if you would like us to have an echocardiogram scheduled for him and maybe check his troponin levels.
Very good. Yeah, go ahead, send him down for echocardiogram, and definitely we do want to check his troponin levels. Thank you very much. And let him know that I'll be down to check on him shortly.
Alrighty, thank you. Bye.
Thank you.
Hello, Mr. Brown. How are you feeling?
Oh, I'm feeling much better, thank you.
Okay, and it looks like your oxygenation is at 95%. It's doing better.
Good.
The doctor would like you to have an echocardiogram, so we're going to take you down there, and we're going to get just a few more labs. We're going to check your troponin levels, just make sure if you've had a heart attack or what. That's what that will indicate.
Okay.
All right,
That's
thank
wonderful.
you.
Thank you, sir.
We'll get you coming in just a minute.
Joe, thank you.
The echocardiogram shows dilated cardiomyopathy with an ejection fraction of 25 to 30%. Normal ejection fraction of a healthy heart is 55 to 70%.
Hello, Jessica. How are you?
Good, how are you?
Pretty good. Okay, I've just spoke with Mr. Brown,
Okay,
and I'm going to go ahead and admit him for observation tonight.
alright,
And what I'd like you to do is go ahead and check his lung sounds every 1 to 2 hours.
okay.
Keep him on continuous O2 monitoring, and let me know if there's any changes in his mental status.
Alright,
And if you have any questions or anything like that, notify me as you can, okay?
alright, I'll notify the family.
Thank you.
Our nursing interventions for heart failure. Elevate the head of the bed. Monitor your respiratory rate, depth, effort, and assess the lung sounds every 1 to 2 hours. Monitor patient's oxygenation continuously. Monitor intake and output. Weigh your patient daily. Provide a restful environment by keeping lights dimmed and limiting the amount of visitors. Schedule rest periods after meals and after activities. Provide patient with a bedside commode and make sure their call light is within reach so they can call for assistance so they are not getting up on their own. Monitor patient's behavior and mental status for sudden onset of restlessness, agitation, confusion, and lethargy.
Has the doctor been in to explain your diagnosis?
He has, he told me it was something, some congestive heart failure of some kind.
Would you like me to explain more about that? Okay. Okay, Mr. Brown, CHF, congestive heart failure, is caused by a cardiomyopathy, and that is the measurable deterioration of function of the heart muscle called myocardium. A healthy heartbeat is about 60 to 100 times a minute, providing oxygen in the blood to the rest of the body. Now, as you can see from this diagram, the lower left chamber of the heart is called the left ventricle. It is the main pumping chamber. A prior heart attack, high blood pressure, or coronary artery disease can lead to congestive heart failure. These conditions can impair the efficiency of the heart, decreasing output of blood volume pumped to the rest of the body. The heart attempts to compensate by beating faster, and the ventricle muscle may increase in size, becoming an even less effective pump. When the kidneys sense the ineffective blood flow, they attempt to compensate by retaining more water and sodium. This excess fluid retention often causes fluid retention in the tissues called congestion, and this results in swelling and an increased strain on an already weak heart. the progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure. Common symptoms of this are fatigue under exertion, dyspnea or shortness of breath due to the collection of fluids in the tissues of the lung, and peripheral edema, which is swelling in the legs. People with cardiomyopathy are often at risk of dangerous forms of irregular heartbeats and sudden cardiac death. The most common form of cardiomyopathy is dilated cardiomyopathy. Dilated cardiomyopathy, or DCM, is a condition in which the heart becomes weakened and enlarged and cannot pump blood efficiently. The decreased heart function can affect the lungs, the liver, and other body systems. In DCM, a portion of the myocardium is dilated, often without any obvious cause. The left or the right ventricular systolic pump function of the heart is impaired, leading to progressive cardiac enlargement and hypertrophy, a process called remodeling. Okay, Mr. Brown, I have some education for you on your medications. The doctor is likely to prescribe some of these. There's 4 main medications that deal with CHF. The first is your ACE inhibitors. And ACE inhibitors inhibit ACE, which is angiotensin converting enzyme. These are your prill medications. They usually end in prill, like lisinopril. And they have the net effect of lowering your blood pressure. They lower your preload. And they lower your afterload on your heart. So it makes it easier for your heart to pump. Just gives it an easier time. Now, there's a couple things you want to watch out for this drug. It's not all the time, but sometimes it causes angioedema, which is the fluids on the heart. You can look out for a red swollen tongue. If that begins to happen, you want to stop. You also watch out for a cough. And also, because it causes the elimination of sodium out of your bloodstream, you want to watch out for electrolyte imbalances. Conveniently, this is ACE. Here are the 3 things you want to watch out for. Now, for the second drug, under B stands for beta blockers. That's your beta blockers block your B1 receptors. And these are your LOL. We'll do prill. Your LOLs like metoprolol, carvedilol, and these essentially relax the heart. Your beta-1 receptors are receptors that stimulate your sympathetic nervous system, so it's your fight or flight. So essentially it's lowering or decreasing your fight or flight, saying we don't need to fight or flight right now, so just relax. And that's mostly what all 4 of these drugs are doing, is causing the heart to relax. They increase vasodilation. I'll be here all day if I spell all of these. So vasodilation. I'll try to use abbreviations here. They also decrease your heart rate. And again, like carvedilol or carvedilol, which is Coreg, metoprolol, these are your LOLs. The C stands for calcium channel blockers. Calcium channel blockers. They do what? They block calcium channels. Calcium channels bring stiffness and rigidity to tissues in your heart and your vessels. So they decrease the hardness of the tissues and essentially say, relax. So to both your heart and your vessels. Lowers the pressure lowers pressure. Amlodipine is one example of this. Can't spell today. Too much pressure, I suppose. Okay, amlodipine, and diuretics is D. And those are, let's see, like hydrochlorothiazide. Often they end in IDE. Not all the time. Furosemide, hydrochlorothiazide. But in any case, these lower your blood volume. And essentially ones that lower the volume are lowering the pressure to go into the heart and the pressure to come out of the heart, and makes it just an easier time for the heart. That's something you want to watch out for, though, is on all of these is your overall blood pressure. You just want to know what it is before you take them, particularly with some of them. With some of them that slow your heart rate, like the LOLs, carvedilol and such, you want to take your heart rate before you take, within a half an hour of taking the drug. You want to know what your heart rate is and your blood pressure, and that will keep you safe on all of these. Some of these, like furosemide, you want to watch your potassium and other electrolyte values, because getting too low is dangerous. And those are the 4 basic CHF medications that you'll be prescribed. The doctor may change from one to another to see which one works the best for you, but the overall picture is your heart has been working too hard to get its job done, and it is going in a downward spiral. And these will take the pressure off and allow it to function at its acceptable rate and pressure. All right, thank you very much for listening.
Client teaching for patients with heart failure. Teach your patient to weigh themselves at the same time every day. Monitor their blood pressure daily. Increase activities gradually. Avoid extreme temperature changes. Strict adherence to drug regimen. Eat small, frequent meals throughout the day that are low in sodium and low in cholesterol. Know the signs and symptoms of heart failure using the acronym FACES, which stands for fatigue, activities limited, chest congestion and cough, edema, and shortness of breath. Our nursing diagnoses: impaired gas exchange related to ventilation perfusion imbalance as evidenced by low oxygenation and dyspnea on exertion. Decreased cardiac output related to altered contractility as evidenced by decreased ejection fraction and S3 heart sounds. Risk for activity intolerance related to weakness, fatigue, and shortness of breath on exertion.
What does the fox say?
Ring ding 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 ding.